Good evening, and welcome to our webinar on achieving physiologic birth. My name is Dr. Kenneth James, and I'm an OBGYN with Orange Coast Women's Medical Group at Hoag Hospital. We are a group of 27 physicians, 3 nurse practitioners, and 6 of the most amazing, talented, professional, and caring midwives in California. My personal transformation from a traditional medical OBGYN to a more holistic practitioner started when I moved to California and had the opportunity to help cover a group of midwives, including one of our own, Lisa Sherwood. They taught me to sit on my hands and allow the natural physiologic process of labor to progress. Physiologic, that doesn't mean just not getting an epidural. It means allowing the natural expected course of labor to progress without intervention. I was so impressed that I started my own midwifery practice. 2 years ago, I had the privilege of merging my private practice with Orange Coast Women's Medical Group and help open up the Fudge Family Birthing Suites at Hoag Irvine. Here, our midwives have private rooms to allow physiologic birth. We have labor tubs, rain showers, walking gardens, sound bars, aromatherapy, intermittent fetal monitoring, no routine IVs, and a team of supportive labor nurses. How does that sound? I'm here tonight to tell you that your birth wishes can come true. Positive people will promote the perfect birth. All you have to do is surround yourself with people who have like wishes. Your partner, professional birthing doula, supportive labor nurses, and the best damn midwives, period. Welcome to the Hoag family. I guarantee you will not be disappointed. How cool is that? Tonight's talk is on physiologic birth with midwives. We've had midwives around Orange County forever. We've had midwives in the hospital for many years, and now we actually have birthing centers to allow physiologic birth in the hospital. Here's our team. You can see myself, and we have 6, again, amazing, fantastic, professional, highly trained, certified nurse midwives, which will tell you what the difference between a certified nurse midwife and a regular midwife is later on with our professional. So why should we achieve physiologic birth? You should achieve physiologic birth because that's what nature made you do. It's the beautiful process, the easiest transition. It makes the baby happier, the mom happier, and how cool is it that you can achieve a labor or a birth the way that you wanted to, and maybe the way that your body was intended to. Now, midwifery is not new. I'll tell you something, my great-great-grandmother was a midwife, and then the rest of the family all became OBGYNs. Midwives have been around forever. Before 1920, every baby in the world was delivered by a midwife. There were no physicians in hospitals, and physicians did not go to people's homes to deliver babies. In the 1920s, they opened up hospitals. They called them lying-in hospitals, and then delivery or obstetrics became a medical complication, right? It became a medical procedure to give birth. Years and years and years go by. Women said, "Hey, I don't want to have a medical birth. I don't want to be drugged up. I don't want you to knock me out, pull my baby out, and me wake up a couple days later. We want to bring natural labor back." So hence, in the 60s and the 70s, Dr. Lamaze, hypnobabies, Bradley, Dr. Bradley, et cetera, all helped bring back natural childbirth. And slowly but surely, it started taking over. And now we have an amazing program. We get, again, 6 amazing midwives who will give you the birth that you're looking for in a safe and healthy fashion at the Hoag Hospital, Fudge Family Birthing Suites. So now let me bring on the midwives. You don't need to hear me talk anymore, and the presentation will just become even more fabulous. Welcome to our presentation.
Well, hello there. My name is Cambria Tuttle. I am a certified nurse midwife here at Orange Coast Women's Medical Group, also working with Hoag. And and alongside the amazing Dr. Kenneth James, who so happily opened up this presentation and is so supportive of what we are doing. So to start off, I'm just going to go ahead and define physiologic birth, kind of touching on what Dr. James had mentioned. A normal physiologic labor and birth is one that is powered by the innate human capacity of the woman and the fetus. So again, just touching on that normal labor and birth actually does not require any medical intervention. So this brings us to what are the characteristics of a physiologic birth. So physiologic birth also is defined as having a spontaneous onset and progression of labor, giving that first stage of labor the ultimate time frame to actually just, like Dr. James said, sit in our hands, watchfully wait. A lot of our job as a midwife is to actually just kind of hold your space, recognize normal and abnormal, and really just keep a low-tech, high-touch type of environment for you. Biological and psychological conditions are also very important to promote effective physiologic labor, which we will dive into in our next slides with some of the other midwives. We then expect a vaginal birth, and that's including the infant and the placenta. We also expect a normal birth of the placenta, which we will get into. And we also respect that there's physiologic blood loss and what that looks like, again, differentiating between normal and abnormal blood loss. We then try our best to promote an optimal newborn transition, which includes that lovely skin-to-skin contact with you and your baby, and no infant-mother separation to the best of our ability. This also will definitely also improve your early initiation of breastfeeding, having those special moments defined right from the start. So what we try to avoid, again, this isn't so much as a presentation of going against what we do in hospitals and against what has now become modern birth. This is actually just an appreciation and a teamwork environment. So we are trying our best to avoid medical intervention that is unnecessary. Like Dr. James talked about earlier, is what kind of happened when we pulled so many people into the hospital system. Intervention became quite normal. Where midwives, the way we are trained, is actually we are normalizing that normal labor and birth takes account for most women in their lives. It is a normal life cycle event. So we are just trying our hardest to appreciate intervention when it is medically necessary versus being routine or standard and unnecessary. So again, we appreciate medical intervention. We are trained to do so, but we do it much, much less likely in the modern setting right now in the hospital. So things we try to avoid, of course, starting is an induction of augmentation of labor. We really value and feel that respecting the body to have the natural course of going into spontaneous labor is a huge promotion of physiologic birth. So again, we don't practice induction or augmentation unless medically necessary. We also provide a very, very, very supportive environment. We try to avoid an unsupportive environment, which might look like something kind of like this picture: bright lights, lack of privacy, multiple people that may not need to necessarily be in the room or not having a role. And again, lack of support persons, kind of surrounding you with people who promote and are trained to recognize physiologic birth. We also do not practice time constraint influences. We really try our hardest to preserve that labor takes time. With new research, we see that traditional labor curves used in the past aren't actually utilized anymore and have shown to have negative effects on women actually in the United States. So we know to practice giving a lot of patience and time for that first stage of labor. We also try to avoid nutritional deprivation. New studies, of course, are showing and even recommending that women do drink and eat during early labor and throughout their labor safely. We avoid opiates, regional anesthesia, or general anesthesia at all costs. Again, if it's medically necessary, we talk with our patients through this and we recommend and counsel on the risks and benefits of these. We also avoid operative vaginal and cesarean birth, of course. We want you to have that physiologic vaginal birth. It is one of our top priorities for you. We do immediate cord clamping and delayed cord clamping. We do not do immediate cord clamping. We perform delayed cord clamping. And again, we have research there supporting that practice as well. We do not try to separate the mom and the baby. So we practice at Hoag Irvine a rooming in situation, and it's also actually a room where you will labor, give birth, and recover and start your postpartum journey all in the same room, which again just promotes a home-like setting and just comfortability for you and your baby and your new family. We try to avoid any situation in which you feel threatened or unsupported. We know that one of the biggest threats to physiologic labor is actually a mother's fear, and we have to really engage with our patients, engage with our birthing people to try to work through fear to allow their body to take over and, of course, start that journey of physiologic birth. So this will bring us to our next midwife. She is incredible. Her name is Mallory, and she'll be talking to you a little bit more about why you should do this.
Hi, my name is Mallory Monroe. I am also a certified nurse midwife at Orange Coast Women's Medical Group. If you're watching this, you may already be sold on the idea of having a physiologic birth. You might not need any more information on or convincing to do it, but it's always great to know what the benefits are. But if you're watching this wondering, why would I want to do that? That seems sadistic or crazy. There are lots of benefits to mom and baby to have a physiologic birth. And we also just support women in whatever you want to do with your birth. It does not necessarily have to be unmedicated to be physiologic. And you can also achieve a wonderful, empowering birth with an epidural or with pain medication. But we're going to go into the details of why we believe in physiologic birth as midwives and what benefits they have for mom. So physically, emotionally healthy moms come out as powerful mothers, and that's what we really believe. So benefits for mom, immediately postpartum, you will have less pain. Statistically, we've been able to see that mothers recover quickly from a vaginal birth if they have a physiologic birth. The baby bonding experience is enhanced as well with a physiologic birth. The cascade of hormones that you have when you have a physiologic birth and immediately when the baby is born enhances that bonding experience, which then leads into enhanced breastfeeding. Breastfeeding rates are improved when moms have that physiologic birth. And the transition for baby, when baby comes right up on mom's chest right after birth, their temperature is better regulated. Their respiratory rate is better regulated. We don't have to do as many interventions for baby typically when we have a physiologic birth, which is so fabulous. We've reduced the likelihood of postpartum depression, which is huge for our moms. We really, really like to think about the mental health aspect for our moms because it's not just about the birth. It is so much more than that. And so we really appreciate how beneficial that is for our moms. We see calmer and more settled babies as well. And a huge one that we're getting lots of new research on is the improved gut colonization for baby. Actually, the good bacteria from the vaginal canal as the baby comes through is really important for that baby as throughout the baby's entire life, actually, for different sort of stomach issues and GI things. And it's really interesting the new research that is coming out about things like that. And then more benefits for the baby are reduced likelihood of risks associated with medical interventions. So of course, if the baby is transitioning really well right away, breathing easily, not having problems with blood sugar, then the baby doesn't need to have lots of pokes and prods and medical interventions, and that's always more safe for baby. And that improved bonding is super important, which leads into the higher probability of breastfeeding. And then the benefits for society at large. Unfortunately, postpartum post-traumatic stress disorder is a huge issue that we're dealing with on a whole with our society, and postpartum depression, postpartum anxiety. The birth experience can really influence how our moms recover after their delivery. And so having an empowering birth experience leaving feeling like a powerful woman, appreciating what your body can do instead of feeling broken. That's just a huge gift, and we really feel strongly like we want to try to provide that kind of experience to our moms. And the reduce of out-of-pocket cost by reducing intervention and cesarean delivery, that's huge. Of course, everyone wants to save money, and then thinking about how that affects you afterwards. If you have a hard birth and a hard delivery and then a huge bill on top of that, that's a big detriment to your life, and we want to try to reduce that as much as possible. And then reducing chronic disease by improving likelihood of breastfeeding. We could have an entire webinar on breastfeeding and the benefits of breastfeeding on top of this physiologic birth webinar, but it's amazing to think about the cascade of positive things that we can see down the road. Babies that are breastfed are more likely or less likely to have diabetes, high blood pressure, obesity later in life. So everything that we can do to help promote things with breastfeeding, starting with pregnancy and birth, that's just so amazing to think about years down the road, the benefits that'll have for that child in their life. And then to reduce intrapartum morbidity through the avoidance of surgery. That is a huge one. Especially with our first-time moms, we really, really want to promote vaginal birth. When moms who have vaginal births with their first baby, they are so much more likely, almost 90% chance of having a consecutive vaginal birth with every other baby that they have. And moms who have C-sections with their first babies are more likely to have C-sections with the rest of their births. And that is a really important thing to think about, because we really want to improve morbidity and mortality for moms in this country, and especially in our practice. And promoting vaginal birth overall is a huge factor in promoting improving morbidity and mortality for our moms. So we want to talk about the difference between doulas, midwives, and OBGYNs and our team approach with our next presenter, the fabulous Lisa.
Thank you, Mallory. Hi, everybody. My name is Lisa Sherwood, and I'm the original, I guess you would say, midwife who did work with Dr. James many years ago. And I think that as a labor nurse for 20 years, it's actually what inspired me to become a nurse midwife, because I was disappointed as the years went on as a labor nurse and seeing how women were treated during labor and birth, but how far and the distance became between the care providers and the women having babies, and left to just kind of be on the bed and be rotated back and forth with an epidural, and very disconnected from their care providers and from their individual birth experience. And that's the original reason why I became a midwife. It's been 22 years as a nurse midwife, and it's a career that is an amazing career, and I wouldn't trade it for anything. I've really enjoyed watching how it's changed and transformed over the last 22 years. And I've got to say that with the new nurse midwives that have joined our practice, I learn something new every day from them. Their energy, their desire to serve women, and their passion about birthing is amazing. And so I hope that you will consider joining our practice, or at least looking at it as a possible alternative to traditional kind of obstetrical care that's offered in the local community. So my job is to talk a little bit about the differences between physicians, midwives, doulas, and tell you a little bit about what they do individually and what we do together. And so I'm going to kind of go backwards. I'm going to start with the physician, the OBGYN doctor, who is a very important and integral part of our practice. We do have, as Dr. James alluded, 27 obstetrician gynecologists in our practice, so we have many physicians. The most important thing about that is, well, a few things. Your safety is the most important thing to us, and as much as we want to honor, respect, and guard your birthing desires, we also know that sometimes things go differently, and we don't ever want to say, well, we can only do this or that for you. We want to be able to support anything that you might need during your pregnancy and birthing journey. And so our physicians are there to support us, to consult with us, and to help us and help take care of you. But their role with our midwifery patients and women is really to be in a supportive role, to come alongside us and help us when we're asking, like, maybe we need to do something a little differently, or we're concerned about something. They're there to support us. And so that's a big benefit from our practice in the hospital setting, that we can do whatever we need to do to take care of you. And we have physicians, obstetricians, we have anesthesiologists, and we have neonatologists there to help us in case your baby would need anything. The other thing I'd like to talk about is the certified nurse midwifery care and what that looks like. Of course, that's where my passion lies, so that's where I'm going to spend the bulk of my time talking to you. The word midwife actually means with women, with woman, and the motto of the American College of Nurse Midwives is with women for a lifetime. And so we really believe that that relationship starts at adolescence. We see young women for regular gynecologic care and concerns, and I think that gives us a unique opportunity to establish that care and establish that relationship so that as their life moves forward and they get into a more serious long-term relationship, they want to have a baby, they already know, oh, my midwife, I know her, she's supported me through college, and now I'm choosing to have a baby. And so it's more of a natural progression than to join us for care through pregnancy and birth. I think a lot of people are mystified, if you will, by what the word means, midwife. They hear the word and they think, oh, I have to have my baby at home, and there's not going to be anybody there that's really educated to support me and know what to do in an emergency and those kinds of things. So I think it's really important that we dispel that misbelief that the certified nurse midwives in our practice all have master's degrees in nursing, have worked as labor and delivery nurses, and have furthered their education and become nurse practitioners in women's health, and also nurse midwives qualified to take care of pregnant women and birth and postpartum care for those women. So it actually is a very safe and satisfying alternative for the majority of women who have low-risk pregnancies. I think that word low-risk pregnancy is important to talk about because I meet people and they think because they're 37 years old, I'm elderly and now I'm high risk. Or I had an abnormal pap smear when I was 25. I've been told I'm high risk. So those things are not high risk. Many women, the majority of women, qualify to have midwifery care during pregnancy, labor, and birth. And I think it's a great option for many women. I think that as we work during pregnancy, we work to establish a trusted relationship with women and their partners and their extended family. And I think that, as Mallory alluded to, and Cam as well, is that trust is such an integral part and such a pivotal point for every woman, because anybody who's having a baby, if they were honest with you, would tell you, I'm scared. Because many of them, anybody having their first baby has never done that before. And then they hear all these things either on TV or from their neighbor or somebody else who oftentimes tells them horrifying experiences and things like that. Well, I can introduce you to a plethora of women who would not tell you anything like that, the women who we have cared for and served and who have given birth with us. We can introduce you to many women who felt very empowered and felt very accomplished after they gave birth. And I think that really does arise from early in the pregnancy, the support. Like if you're nauseous, if you're vomiting, if you just feel awful, to be supported through that, help through that phase of time. And then as the pregnancy unfolds and people start feeling better, to talk about what do you want that day or night to look like? How can we support you in that? How can we help guide you to the appropriate childbirth education to enhance the experience and for you to gain confidence in your body's ability to birth physiologically, in your body's ability to do the job that we're asking you to do and that you're asking your body to do. And we know that the more connected you feel to your care provider, to your partner, to yourself, to the whole event, we know that that influences how you relate to your baby, connect with your baby, and how you launch into parenting that's going to take you. I have a 35-year-old and a 31-year-old child. I am still their parent. It just looks a little different. Sometimes it doesn't look different at all. And then you get to be a grandma, and that's the reason why you have children, is that you get to be a grandma. Anyway, back to being a midwife. So I just feel like when you develop that trusted relationship with somebody, then you can relax and feel safe, and you don't have to be in a fight or flight mode, and you don't have to worry about what somebody's going to do to you or without your permission, or create some situation that you didn't sign up for. And so those prenatal visits, we spend time layering that with relationship, with answering questions, with building that give and take, if you will, and being able to feel confident and that you can trust us. So that on that day or night, if it's the night, you'll see me. If it's the day, you'll see one of my colleagues. It seems like it goes that way. Anyway, that no matter which one of us shows up that day, that you can look at us and know confidently that we're going to be there to support you, help you have a baby, and whatever that's going to look like. Sometimes it's cheerleading. Sometimes it's just coming up next to you. And I will say, in the queen size beds, I can lay down with you and actually whisper in your ear, "You've got this. You can do it. Just take a deep breath." And it's amazing what we get to do and how we work together and how we work to support you. I could really go on all night, but they're going to not like that if I go on all night. But I think we just are there present with you during pregnancy, labor, and birth. And I think that we look at you as a whole person, not a uterus that just happens to be pregnant. I tell my women, if you were just a pregnant uterus, you could call an Uber to bring you to your uterus to the visit, and then I could put it back in the car and send it home. And it's not a uterus that gives birth to a baby. It's a woman that gives birth to a baby. And you are a woman psychologically, physically, emotionally, and you're carrying the ultimate responsibility around in your belly every day. And that's a daunting task. And we're here to support you through that. I think that's enough for now. What is a doula? A doula is a trained person who is there to assist you physically, emotionally, and to provide care to you. They're not generally trained medically or professionally from the standpoint of a healthcare professional, but they're there to help you find comfortable positions, to provide emotional support, like I said, and to support you through the birth process in a different way. But what's nice about it is we kind of work together like this, in that we work together, but we have some different roles and they overlap a little bit. And so you just get more support, more care, more help. They can come to your home in early labor and help you get into that rhythm of labor for yourself. I tell people that nothing magic happens because you cross the threshold of the hospital, and that's very true. So the more time you can be at home in the first stages of labor, get used to that in a familiar environment with familiar smells, tastes, people, that sort of thing is good. And then transition to the hospital when you're in active labor, and we will touch on that in a little bit. And then doulas also provide care afterward. They come to your home, assist with breastfeeding, and some people are postpartum doulas where they stay and help you with the baby and that sort of thing. So that's kind of the difference between those three entities. The next thing we're going to talk about is how to help prepare for a physiologic birth from the standpoint of how can you be in your best health, you can be mentally healthy, physically healthy, and taking good care of yourself. So we know that exercise and nutrition is helpful for anybody anytime in their life. And so if you can do that and be in the optimum health before you get pregnant, that's great. But if you enter pregnancy and you have issues, then we're going to help get you on some type of plan where you can exercise regularly, eat healthfully. We don't put people on diets. We encourage people to take good care of themselves, and there's many resources to help you be successful with that. We also consider emotional wellness to be very important, and I think that many women are afraid to share some of their real concerns and fears, and I think some women come to pregnancy happy to be pregnant, but have had hard relationships with their mothers or growing up with a lot of different things that bring baggage. There's also people who have had hard birth experiences and come to us with another pregnancy, and it's really important. It would be a disservice not to address how do you feel about everything, and how can we help you get to a place of wholeness and feeling like I can do this, that I can set this aside or at least be heard, so that we know what are the things that are going to either help open the door for you to feel I can just go and have my baby, or things that we need to help you process. Childbirth education with an exclamation point. It's really important to understand what the process is of labor. And when we see you for your prenatal visits, we don't have the time and the luxury to be able to do childbirth education. We can answer questions and we can help you understand what might be being taught to you at a childbirth education class, but finding the type of education that you resonate with. There's so many different types of childbirth education out there, and you just have to kind of explore which one works best for me. Do I Do I want hypnosis? Do I want to do the Bradley method of childbirth? Am I just more interested in an eclectic approach to just help me understand what my body's doing and give me some tools to work with it? I talked a little bit about hiring a doula. There are so many doulas out there, and you have to find the one that resonates with you for that as well. But we really, really, really recommend somebody who can be there with you that is just attentive to you. The midwife will be coming and going and maybe attending to 2 women in labor, but a doula is somebody that would just be there with you consistently throughout the whole experience. Developing a birth plan, something that we recommend, and I don't like the word birth plan, I like the word kind of birth preferences, and I think that it's something to say, in my ideal world, what would that day or night look like? And when I tell people when you're developing that plan, it shouldn't be a 30-page annotated, notebook of every step of the way. I tell people, I'm a very visual person, so I tell people it's like a watercolor. It's like you splash blue, and then you splash yellow, and then you think, oh, I wasn't expecting green, but the blue and yellow ran together, and now I have green. So it's kind of like looking at, these are the kinds of things that I want, these are the kinds of things that are most important to me, to help develop a plan where you have some empowerment and trust and confidence in what you want. And then, again, we've already talked about establishing a trusting relationship with your provider, which I happen to believe is the crux of why physiologic birth is amazing and why our women do so well, is because they don't have to be afraid, and they can trust us that we are there to support and help them have the experience they want. All righty, am I done? A comfortable environment from the start. I'm done. All right, thank you so much.
All right. My name is Jessica. I am also one of the certified nurse midwives here. And Lisa's always a really tough act to follow. I always feel that way when I have patients that come see me after they've been only seeing Lisa. It happened today. I was like, oh man, she's only been seeing Lisa, and now she's got to see me. But yeah, I love how clearly Lisa's able to articulate just how passionate we are about what we do. And one of the things that's really important to us in becoming your providers is creating an environment that feels comfortable to you. And that even starts with the second you walk through the door. We have multiple offices here in Orange County and places where you can come and visit us. We have a couple offices that are really built specifically with midwifery care in mind. Here you get to see our offices at Mission and also in Irvine, and we're working on creating these similar environments in our offices in Foothill Ranch and Tustin at our legacy location, so that we have the opportunity when you come in and meet with us, it's like we're sitting on your couch at home. Those couches there that you see is where we do your fundal height measurements. It's where we listen to the baby with the Doppler, and it's where we just chat and talk. And like Lisa was mentioning, it's just such a great opportunity to get to know you and find out what kind of stuff you're bringing to the table and how we can best meet you to make this experience the one that you're looking for. So how do we make all this happen? How do we put everything together? The reality is there is no one size fits all here. Everybody's different. And that's why those appointments, sitting on that couch talking through things, that little bit of extra time you get with a midwife makes such a huge difference, because we can go into it understanding what you specifically need to achieve your goals. So to start with, we'd love for you to go into labor on your own. That's always the goal. So we try and give you the time to do that. We usually don't even talk about induction unless there's a medical reason to do so until you hit about the 42-week mark. And there's good evidence for why we wait that long. And usually by that point, your body is able to kick into gear. And we always say, we always have a little bit of a party when someone beats their induction. And sometimes it happens by just one day, but it often does happen that way. And you get the chance to be home in your own environment, like Lisa was talking about. It's one of the greatest things about having that supportive environment. What I would always say to people is you're building your village and you're building your toolkit. When you're thinking about having a baby, you really want to think about, like, who is the village that's going to be around me to make this happen? So the doula, the midwife, your care team at the hospital, where you choose to give birth makes a really big difference in how you give birth. When you have an environment that is built to create a village environment for you, where you have your doula, you have your partner, you have your midwife, you have all those key players in place. That's number one in terms of creating the right environment for birth. Of course, your own home environment is going to be the most comfortable place for you. So being at home, resting at home, eating at home, like Lisa was talking about earlier, and then arriving at the hospital when you are actively laboring with your doula and your partner is a great time for us to kind of enter the picture and come alongside you in the actual labor process. And as Cam mentioned earlier, our goal is to avoid medical interventions as much as possible. But again, this is not a one-size-fits-all phenomenon. So there are going to be times when we have conversations. You get dealt a hand where you're laboring for 40 hours with your first baby, you've been at home forever, and now you're at 5 centimeters and things just aren't happening. We will probably have a conversation about what it would look like to release your bag of waters and see if that can help move things along. At the end of the day, though, we're not going to tell you to do anything. We're going to tell you what our recommendations might be or what your options are, so that at the end of it all, you can say that you were in the driver's seat and you got to make the best decisions for you based on the information that you had, so that you had the birth that you wanted. So let's talk a little bit about the toolkit. We talked about building the village. What does your toolkit look like? So essentially for us, that just means what kind of coping mechanisms are you going to learn? How are you going to prepare yourself for this process? You would never wake up the day of the LA Marathon and be like, I've never run a marathon, but today I'm going to do it. Although somebody once, when I said that in a meeting, said, I did that once. And I thought, okay, maybe I can't use that analogy anymore. But for most of us, you're not going to wake up that day and run a marathon. What you're going to do is you're going to train, and you're going to have coaches, and you're going to mentally get in a space where you can do it. And it's the same kind of thing with labor. Labor is a marathon. And you're really having to build a toolkit of different things that you can bring with you to help you cope in labor and get through this process. That could be, like we talked about already, certain classes, Bradley classes, hypno classes. There's lots of options out there. In our community setting, we've got lots of good recommendations for you, but it should always be a class. If you're wanting to do this without medication, or you're wanting a really physiologic birth, take a class that's designed for people who are going to help you, or designed for physiologic birth, people who are going to help you get to that goal, because that's helping you train for the marathon. Other things that are in our toolkit, we have options like those beautiful birth suites that we have, which are equipped with rainfall showers and the big tubs that you can see in this picture, for example. Those are all tools that we can use. Hydrotherapy is a tool that we can use to help you cope with labor. Position changes, as Lisa was mentioning, doulas are so fantastic at this. They're so great at helping you switch it up, try something different. After a while, sometimes a tool that you've been using the whole time, you've been in the tub the whole time, it's been working beautifully, and all of a sudden that tool's not working anymore. You were using relaxation or breathing techniques that were working, and all of a sudden those aren't working anymore. So we dig into the toolkit and we try something else. We try aromatherapy, we try massage and acupuncture, acupressure. There's all sorts of different things that you can use in your toolkit. And in the bottom of that toolkit, there is other stuff that we have available to us at the hospital that we might not have other places. So nitrous oxide is a really great example of that, a breathing gas that you can use, kind of similar to what you use at the dentist office. So it's very short-acting medication, but you can breathe it in, takes the edge off some of those contraction pains. IV narcotics is another example of a tool that we can use. And to be 100% honest, the epidural can be one of the most amazing tools in labor. When you have been given that hand of a really difficult, hard, multi-day labor, and you just need to rest, that is a tool. It is not a failure, but it is a tool. It's always in the toolkit. But the nice thing is when you prep, you've built all these other tools as well that go into that kit that you can pull out when you need them. Then we talk a little bit about, not just physiologic labor, but also physiologic pushing and second stage of labor. And the beautiful thing for us as being able to practice traditional midwifery care is that we get to catch babies in any position you can imagine. I think it's one of the coolest things about what we do. Even in training as a midwife, a lot of times you would see patients with their legs in stirrups, with a bed broken and having a baby in very traditional kind of OB fashion. What I love about our crew is that we catch babies all over the place, in the shower, on the toilet, hands and knees position. We have squat stools that you can push on. And to me, I think it's always one of the coolest things to catch is just the funnest part. And the most fun is that we don't do that ourselves a lot of the time. You guys do that. So partners get to help catch, and moms grabbing their own baby and bringing their own baby to their chest. That is what makes what we do so phenomenal and so different, I think, than what you think of when you think of hospital birth. We really have built something here where we get to do much more traditional holistic birth, but in a hospital setting, which is super cool. In terms of postpartum care, like Cam mentioned, just that immediate skin to skin, the initiation of breastfeeding, delayed cord clamping. We go through all of that when we meet you in the office, but that's definitely all very, very, very important to us and all part of the physiologic process. Dr. James mentioned a little bit about our facility there, the Fudge Family Birth Suites. It is a really beautiful facility, and what's very cool is we got to meet Mr. Fudge, who gave us the money for this particular facility in Irvine. And when Lisa Sherwood asked him, why did you choose to build this facility? He looked at all of us and said, because I learned about midwifery care and I felt like it should be an option. And that is now something that is a huge opportunity for our families in Orange County, and we're just so grateful to have it. It is a beautiful state-of-the-art facility, ground floor. It looks a lot like a hotel in some of the ways that you look at this place. Beautiful floor-to-ceiling windows that we can block out the curtains if we need to, make it more of a dim and comfortable environment. We do have a couple of suites that are specifically designed for midwifery care, so those suites do have our queen-size beds. So Lisa was talking about snuggling up with you on the bed. We can do that in two of those rooms that are designed specifically for midwifery care, low intervention births, so that those rooms are specifically really ours. In addition, there's 10 other rooms that are more standard rooms, and so even some of our more high-risk patients can still give birth with us at the suites in those rooms with the more standard. The only difference is the size of the bed. There's a standard hospital bed in those rooms. But all of our rooms have access to the rainfall showers, the tubs. We have birth balls, we have peanut balls. And one of the things that I have to say about Fudge that I love the most is that we have such an amazing staff there. I think even some of our charge nurses are on today listening to all this, and I'm going to say lots of lovely things about them because I think it's often when you think of hospital birth, you don't think of this type and this style of care. And what's most amazing is that this really does go beyond our midwife team, and our labor nurses that we have there are incredible. They have done so much research and they're learning, and many of them are in school to become midwives, and they're just so excited to be with unmedicated moms who are in the tub or in the shower. It's fun to see their excitement at seeing something different than traditional hospital birth. So they're just a really phenomenal team, and most of them are really excited about physiologic birth and are very supportive of that, and so that's something we're very proud of. The other nice thing about having a birth center basically in a hospital, it's still a hospital, it's still labor and delivery. So we still have access 24 hours a day, 7 days a week. We have OBs working with us right alongside of us. So if anything goes from low risk to high risk, which it can do very quickly in labor, we have them right there with us to help us. We also have access to anesthesia and epidurals, and we also have access to operating suites. We have 2 operating suites right there in the hallway. So if something were to happen and we needed to get baby out quickly, we could still do that very, very quickly. So it really is the best of both worlds in terms of traditional midwifery care, but with that backdrop and that kind of safety net of having all that at our disposal if we need it. So now it's time for questions. I think that's everything. We did get some questions from some of you guys on the live feed. You guys want me to start on mine? Okay. 15 minutes. Okay. So this is just a good opportunity. I'll give you my one question and then I'll let someone else go. But one of the most important questions I think is obviously having to do with where we're at right now in terms of COVID. So one of the questions here is, are there any limitations to birth plans due to COVID regulations in the hospital? Very good question, fair question. What I think is very cool about Fudge Family Birth Suites is that they actually really opened at the height last year of the pandemic when we had that last year surge. And we've never operated without a pandemic because it's that new of a facility. So what's really great to note in that regard is that Fudge has always allowed for partners and a doula to be present always at your birth. So the only restriction now is the state mandate. Anybody that's there that's not the partner does need to have a negative COVID test or proof of vaccination, and that's just the state mandate for all hospitals. So that is the requirement for a doula, and our doulas in the community are fully aware of that requirement. And the partner, if the partner wants to come and go at all, so if you have a small child at home and they need to go home, or your dog needs to be taken care of, and they want to come back, they also need to show proof of vaccination or a recent negative COVID test for access in and out. Otherwise, if they arrive with you in labor and you're actively laboring and they're with you, they can stay with you. That's not a problem. And if they are not vaccinated and don't have a test, they just can't leave and come back. As for you, the laboring person, you would actually be tested upon admission. That's just standard. And once you have been negative tested and everything's negative with you, that you can take your mask off when there's no other personnel in the room. They really don't mind at all. And some of the personnel will ask you to keep your mask on while they're in the room, even with a positive test. But usually in the labor process, there's a lot of give when you're actively laboring. Do you guys want me to do my second one too? Okay. The next one is water birth an option at Hoag? And the answer is no, it is not. You can labor in the tubs, but the actual birth process has to happen outside of the tub. But again, you can do that in any position you like. So that one's a pretty simple, straightforward answer. And I'm going to pass it over to Dr. James.
Okay, my wife's going to kill me, but I'm going to throw a Y chromosome into this talk for a second. One of my favorite scenes in a recent show is in the Outlander. You guys watch the Outlander? You all watch the Outlander, right? So there's an amazing scene, I think it's season 3, where Claire is pregnant, and then she goes back in time, right? She goes back from 1700 to the 1947, I think. And there's a scene where she's in the hospital and she's giving birth, and she's on the table, and the doctor says to the anesthesiologist behind her, he goes, "Give her the medicine." And she's like, "Whoa, I don't want any medicine. I want to be awake, and I want to feel my baby, and I want to experience the birth." Hence, like she was in 1747, not 1947, where births were in a hospital with a doctor who told women how to give birth, not were there to assist women in birth, which as we do now, or as midwives, assist the women in giving birth, because they give birth, not the doctor. So it's a great scene. You can Google it. Again, sorry, it's a little bit of a, Y chromosome thing, and I got a lot more to go to, but so I'm just going to do a quick medical question. The question is, what do you hear about VBAC strategy and how it changes in pregnancy if it's high risk? Well, VBAC is high risk, period. But our midwives do VBAC, unlike anywhere else, in a safe, healthy environment, in the hospital, with doctors right around the corner. But our midwives do VBAC. They allow VBAC. Again, natural physiologic birth. Does that help VBAC? Of course it does. It's just birth, okay? But you're in a safe, healthy environment with the best medical care in Orange County right outside the door. So give a call, ask about VBAC, ask about the midwives. Listen, some people are not good VBAC candidates, but most people are, and our midwives are happy to take care of you. All right? Mallory, come on.
Okay, the question that I have is, can we request how long we'd like to delay cord clamping? For example, I'd like to deliver placenta before clamping cord. So that's the famous lotus birth. So one of the conversations we love to have with patients is just risks and benefits of different things before the birth happens when we're talking about their birth plan. So there's so many benefits to delayed cord clamping, and we love talking about how beneficial it is to baby, giving back some of that blood to baby before we stop the pulsation by clamping it. So we like to wait for the pulsation to stop before we clamp and cut the cord. We will talk sometimes about the risks, or every time we talk about it, we'll talk about the risks of delayed cord clamping as well, which are fairly minimal. But there is an increased risk of jaundice sometimes, depending on how long you're delaying the cord clamping. So those are decisions for you to make. We'll make as a care team with you knowing all the risks and benefits. And at the end of the day, the placenta and the cord is your body. It's part of you, and we really can't touch it without your consent. The only time that we would be cutting and clamping the cord in a quick manner would be in case of an emergency that the baby really needs urgent help directly after birth with breathing, which is usually a quick kind of moment. And so that would be a quick conversation that we would have to have. But that is not the norm. And we like to just have a conversation first so that you can make an informed decision about what you want for your birth plan. Do you want me to do the second one? So the second question I have is, how long do patients usually stay in the hospital? That one's pretty straightforward. After a physiologic vaginal birth, patients usually stay between 24 and 48 hours. A low-risk mom with a vaginal birth could go to the home almost immediately after a vaginal birth within a few hours, but we do like to keep a close eye on the baby, and a lot of our things that we do in the hospital to make sure the baby is healthy and passing all of its tests happen around 24 hours. So we'll look for things like jaundice. We'll do a test to make sure that the structures of the heart are normal in the baby, and it's important that we do it at 24 hours. And if there's any extra care that's needed, then it'll be recommended that you stay up to 48 hours, and that's usually related to the baby. Of course, if there's any complications with the mom's birth as well, that could increase the stay. And then if a C-section is needed, typically the stay afterward would be between 2 and 4 days.
Alrighty, so I have a few questions here, so I'll try to be as quick as I can since I know time is ticking. The first question I have is, does this practice happen at Hoag Newport as well, or is it specific to Irvine? So at this time, we are, the Midwives of Orange Coast Women's Medical Group are specific to Hoag Irvine. We have the amenities there. The facility, like Jess was touching on, was kind of built to promote this low intervention setting, promoting physiologic birth. So that's kind of what we're committed to. That's our vision there. And there are only 6 of us. So we are just working hard to try to get this kind of up and running. And again, it is just specific to Irvine. I know and would love to touch on that I work with some fabulous obstetricians in my group here. And I do know and hope that there's other fabulous obstetricians open to promoting physiologic birth. So I urge you as a patient, when you are speaking with your provider, to have these discussions early on in your pregnancy, talking about birth preferences and what policies entail and how they practice. Because again, having that supportive provider, midwife, or obstetrician is extremely crucial to, again, your birth and how that's going to look for you. My second question, is it possible to have a physiologic birth even if I have to work with an OB-GYN due to being high risk? Yeah, the answer is yes. And again, just touching on what Lisa said, I think it's very, very important to then surround yourself with support for a physiologic birth. And that comes from your provider, that comes from your partner, and possibly, and I hope, a doula. Doulas are essential at the bedside in promoting physiologic birth. So if you are high risk, you can have those conversations with your medical provider, your obstetrician, about what might be needed. But then again, you can have that compromise with the doula, filtering in and asking and helping to advocate for some kind of meet in the middle for you to accomplish your physiologic birth. And I would like to also just touch on, in this practice, we are really lucky, and I am so proud to be a part of it, because we are such a collaborative team here. The Midwives of Orange Coast Women's Medical Group do get to care for women who might fall into a category of being more moderate risk or at risk for being high risk, not necessarily high risk, but at risk for it. So again, we team up with our OBs here. They are excellent, And we can always conversate and have those consults beforehand before taking on a patient or having them throughout their prenatal care. Third question, how far into the pregnancy should you secure a doula? That is a great question. It's there's no right answer really, but I do tend to encourage my patients that I see to probably secure a doula by 30 weeks or so, just because usually by that point we're kind of diving into, okay, what are we expecting? What are those priorities? And having that doula on board at that time, they will be able to kind of see you before birth as well in your home. A lot of the doulas I work with will usually do about 2 or 3 visits at home with you to just go over everything. And that also just builds that relationship. You know, you want to have that ongoing support and just trust in your doula as well as your midwife. So the sooner the better, but that also doesn't mean to discourage you away from hiring a doula if you're 36 weeks. I have plenty of people who finally do start to realize and want that doula support by the end of their pregnancy because of how much they've learned throughout those precious 36 weeks leading up to that point. And we have doulas who are happy to take you on. We have amazing resources, a good community for you to pick one. Sorry, I'm being rushed. 4th question here. How long can your water be broken before induction is needed? So this is quite controversial. A huge study came out called the PROM study that actually supported why it is actually safe to wait for a spontaneous labor actually up to 24 hours. The study actually waited until 72 hours. What we do find, though, after 24 hours is the risk of infection does increase about 2-fold. So usually by the 24-hour mark, we do start to have that conversation about augmentation.
I'm back with one more question, another VBAC question. So the question is, how is the strategy different with a VBAC than with a normal birth, and would appointments be with an OB? How is the approach to labor interventions different? I would say actually we don't really feel like we treat you that much differently as a VBAC. We will take necessary precautions though. So for example, we talked about the midwife suites versus the other suites. You would actually be in a regular suite as a VBAC. And we would do continuous fetal monitoring instead of intermittent monitoring where we're only listening occasionally. And we do recommend that you have a IV in place because of the potential risk for bleeding. So there are those kinds of things that obviously, again, it's never going to be one size fits all. So those are kind of the things that we're looking at in terms of your increased risk. You don't have to see an OB all the way through. You get to see an OB to talk about consenting for a VBAC and a trial of labor after cesarean because you will need to sign a consent form saying that you understand the potential risks of that. And that is done by a physician. But by and large, you'd get to see the midwives throughout the majority of your pregnancy.
Okay, hello again. We're going to do this very quickly because we're at the end of our presentation. One of the questions that I have is, if we want an epidural, is labor and delivery on our back the only option? And the answer to that is absolutely not. Many people will have an epidural but still have the ability to move about and change position. You can't get up and walk around, but we have people who get on their hands and knees who've had an epidural, and you can birth still. We don't put people in stirrups. So we do side lying, we do hands and knees if you're able to, those kinds of things. So we really move it around and rotate you and to the best of your abilities and what feels comfortable for you. The last question I have is, what would warrant an induction for patients under the midwife's care? So I think that by and large, the main reason we end up having to schedule or promote induction is when pregnancy goes close to 42 weeks. We know the placenta was designed to function for 40 weeks or 9 months, and it usually is happy to function a little longer. But we know that at 42 weeks, there's increased risk of the baby passing meconium, the baby not tolerating labor as well, and requiring further intervention. So we like to really find that spot where 41 and a half to closer to 42 weeks that we can help induce your labor so that your baby can be born at that point in time. I think induction gets a really bad name because Pitocin is something that's oftentimes heard that it's used aggressively and starting inductions with hardcore Pitocin. And I think that most of our inductions we start the day before, and we use something called a cervical ripening balloon, where we introduce a little small catheter through the cervix and then ripen it by filling that with fluid, and it acts mechanically to soften, thin, and open your cervix. And that can be done at home. And then you come the next day and we talk about what we need to do to promote your labor. So that's how we do it. But mostly overdue is a consideration. Some women develop high blood pressure that turns into preeclampsia, those kinds of things, baby's not growing well, or certain things where then we recommend the baby be born. What happens if you happen to give birth while you're in the tub? Well, then you give birth while you're in the tub. And then the midwife gets in big trouble and, that sort of thing. I mean, come on. So babies, are born in a lot of places, and I can tell you that I've caught babies in the back of minivans, I've caught babies in an elevator, and I've caught babies in the tub. And so if a baby's going to slide out in the tub, the baby's going to slide out in the tub. We're not allowed to intentionally have women birth in the tub. Our tubs are big and deep, and we're not going to go swimming with you, so it's a little harder to birth in the tub. But if a baby is born in the tub, the baby is born in the tub. All right, that ends the questions for tonight. Thank you so much for giving up your Thursday evening, for joining us. We look forward to seeing you, and hopefully consider birthing with us at the Hogue Fudge Family Birthing Suites. It's a little bit hard sometimes to call our office and to get an appointment, but it may be very much worth your while to just schedule a consultation visit where you can come down, have a chat with us, and see if we are a good fit for you. Again, thank you so much, and if you're expecting a baby, we wish you the best and hope to see you soon. Thank you.